Excellent. So our next speaker is actually terrific to welcome her back. We've had Dr. Helena Chui present at our conference before, but we're more than delighted to get updates. She's a professor of neurology and chair of the Department of Neurology at USC, University of Southern California, and she's going to tell us about vascular factors and cognitive impairment and their relevance to clinical practice.
Well, this is a beautiful trip for me. Come down to San Diego. I see there's no fires on the way down. It's something Mary told me about last week. We have fires down here. It's something we share between Los Angeles and San Diego counties these days. Well, thank you, Dr. Galasco and Mary, for inviting me back. The title of my talk today is Vascular Factors and Cognitive Impairment. And I'm not going to actually talk about vascular dementia or even too much about vascular cognitive impairment. I thank Jody Corey Bloom for giving you the textbook summary of that already. You heard yesterday about how vascular factors are modifiable and how maybe treating blood pressure, diabetes, and cholesterol, we could reduce our risk of Alzheimer's disease. But I wonder how is that? And so I'm going to share with you today some of the new data that say how vascular factors are related to Alzheimer's disease. So Alzheimer's disease has its own vascular disease. It's when amyloid, which is part of the Alzheimer plaque, also gets into the blood vessel, and then it's called amyloid angiopathy. And also, Alzheimer's disease, the beta-amyloid, can interfere with insulin signaling in the brain. And so sometimes you might have heard that Alzheimer's disease is a type 3 diabetes. How many of you have heard that? Yeah, but I think that's very confusing, and I don't actually like to, because it's going to take me 10 minutes to explain what that means. But I will try. Okay, this number 2 is vascular factors, and by that I'm talking about hypertension, diabetes, high cholesterol. You might say smoking. How do they relate to Alzheimer's disease? Or how do they relate to beta-amyloid and phospho-tau? So here I'll talk about how beta-amyloid is cleared across the blood-brain barrier. And so you need a healthy blood-brain barrier. And cholesterol is important and may affect how beta-amyloid is cleared by macrophages. So there are ways that the health of the blood vessels or things like cholesterol can interface with the metabolism of beta-amyloid and phospho-tau. And so that may be why at this time, before we have a more specific medication that's effective directly against beta-amyloid and tau, it's still important for us to keep our blood vessels very healthy. Now, the chart here comes from an epidemiologic study. It's not a memory clinic. This was going out into the community and finding out who has cognitive impairment and dementia and what is the likely cause. So this is called the Cardiovascular Health Study. It was a collaboration among 4 different universities. And the white here shows the number of dementia cases that were clinically attributed to Alzheimer's disease. And the red are vascular. I think Dr. Corey Bloom mentioned 5% in a memory clinic, but in a population study, 12%. And then the yellow here is the mixed dementias, where the researchers said the dementia is due probably to a combination of Alzheimer's and vascular, and that's another 17%. So when you add the red and the yellow together, you got about 30% of dementias may be actually due to vascular disease. We're not even talking about how vascular factors might increase Alzheimer's. When we're in the clinic and we find someone with cognitive impairment, we're trying to say, is this neurodegenerative? Is it vascular? Because that's like 30%, even alone or in combination with Alzheimer's. Or is it metabolic, like low thyroid or low B12 or too many medications, where we can actually replace B12, replace thyroid, or discontinue medications and improve the person's symptoms. So I've shown yellow here, things that we can do that can improve function. For neurodegenerative diseases, a big box for Alzheimer's, a medium size for dementia with Lewy bodies, and frontal temporal dementia gets a lot of press, but it's actually not that common. We don't really even, we have some, we don't have anything that can stop the progression. We do have a number of medications that improve symptoms. So they're shown in green here. The symptoms are still are improved, but the disease is still progressing. So these are the cholinesterase inhibitors, memantine, antidepressants, antipsychotics. The only group that we can actually stop the progression or slow it down are vascular. And that's why I put a red here. You can actually slow it down or stop it, and that's by managing blood pressure, diabetes, cholesterol, and using antiplatelets or warfarin to lower the risk of stroke. Now, to put in perspective stroke and Alzheimer's disease, the Framingham study outside of Boston shows the lifetime risk for women and men of Alzheimer's disease, climbing here after age 65 to about 18% for Alzheimer's disease, and for stroke here over 20%. And for men, Alzheimer's disease maybe 10% lifetime risk, and stroke about 18%. So you see men have more risk for stroke than Alzheimer's disease. So one of Dr. Corey Bloom's questions was which of the above were thought to relate to Alzheimer's and which were not. Which were not. That was the blue eye color, the eye color. But clearly gender, women are more lifetime risk for Alzheimer's disease and even for stroke, when you consider that women live longer over age 95. So for us, in aging, the biggest threats to our mental and physical health are Alzheimer's disease and stroke. Now, vascular risk factors like hypertension, diabetes, they cause a train of risk to the brain, shown in blue here, where you can damage brain structure, damage synapses, and cause an impairment of cognition and our quality of life. So that's one train that's well known, and this is the stroke train. When the blood vessel here gets occluded or it breaks, you have vascular brain injury, which is manifest clinically as a stroke, and then you have brain damage and cognitive impairment. And this train wreck is called stroke, or vascular cognitive impairment, or vascular dementia. And then the second train here is a number of genes, now probably 12 genes and growing, but the largest risk-associated gene is apolipoprotein E4. These genes, and there's a few familial ones that you heard about this morning in the Diane study, these genes increase beta-amyloid and tau, which causes degeneration of synapses and progressive loss of cognition. So the question I'm focusing on this afternoon is really not this train, which is the vascular cognitive impairment or dementia, but are there interactions between these two pathways? Now, one I've mentioned already, that is if you have Alzheimer's disease, and particularly if it's related to apolipoprotein E4, there's an increased risk of having amyloid in the blood vessel itself. And that's called amyloid angiopathy, or CAA. So that's one way that Alzheimer's disease itself causes a vascular problem. And I'll show you just some data from our own study. It needs to be replicated, where low HDL cholesterol appears to be a risk factor for beta-amyloid. So it's another way which vascular risk factors may cross. So the two hallmarks of Alzheimer's disease are phosphorylated tau, beta-amyloid, and this is a very instructive slide in terms of the symptoms of Alzheimer's, which follow the distribution of tangles accumulating in the hippocampus, causing atrophy of the hippocampus and loss of the ability to form anterograde memories, like Dr. David Salmon told you yesterday. We think the disease starts with beta-amyloid, which then starts the phosphorylated tau. The beta-amyloid actually doesn't map as well to the symptoms as the tangles. And you just heard a very nice talk by Dr. Brewer about the progressive atrophy of the hippocampus in Alzheimer's and the accumulation of beta-amyloid in a Pittsburgh Imaging B PET scan. Now, this has been known for some time that the cholesterol concentration in the neuron bilayer, the cell membrane of the neuron, which is made up of lipids, the cholesterol shown here in wavy areas here can affect whether beta-amyloid is produced or whether another type small fragment is produced. So if the membrane is rich in cholesterol, there tends to be a predilection toward the production of A-beta, which is a more toxic species. Now, beta-amyloid, we don't know how much we're making, but we're all making it while we're sitting here. And in the pig, the Yorkshire pig, Richard O'Brien, he took like 6 pigs. I should have shown the slide. I took it out, but now I have to describe it. He took these pigs and he cannulated their artery, the carotid, and the venous drainage system, the superior, the jugular vein coming back to the heart. And he calculated the amount of beta-amyloid that was being produced by the brain. And it was billions of molecules, 1 billion molecules every second. So that was just amazing. Why are we making all this beta-amyloid? The pig is very much like us, of course. So we have to clear this amyloid. And there's 3 ways you clear amyloid. One is it's broken down by macrophages, by enzymes, like neprilysin or insulin-degrading enzyme by macrophages in the brain. But a huge amount of beta-amyloid is cleared into the bloodstream across the blood-brain barrier. And this time it's going from the brain to the blood. And then another third pathway that's very fascinating is that some beta-amyloid goes out around the vascular sheath. Here's a picture showing it going out around the vascular sheath. It turns out it's going out around the veins, around the vascular sheath. So this is important because it shows the health of the blood vessels is important for clearing beta-amyloid. This is a tough slide. This is showing how diabetes, how do I get from here? increases phosphorylation of insulin substrates. This is well, in Alzheimer's disease, insulin signaling is impaired. So here, normally insulin binds to a receptor, the insulin receptor, and the insulin receptor then activates an insulin receptor substrate. But in Alzheimer's disease, in autopsy studies, the insulin receptor substrate is phosphorylated in many places and it's inactivated. It's like tau is very phosphorylated in Alzheimer's. So the early studies from autopsies said that in Alzheimer's disease there's a problem with insulin signaling. There's, in a way, an insulin resistance in the brain. So that's how people started to call Alzheimer's a type 3 diabetes. But diabetes means, diabetes mellitus means there's sugar in the urine due to a high glucose, circulating glucose. Well, Alzheimer's disease doesn't cause a high circulating glucose. It doesn't cause a glucose in the urine, and it's not related to any problem in the pancreas in secretion of insulin. So it is confusing to say that Alzheimer's disease is a type 3 diabetes. Did you get that? Okay. Now, from our own studies with PIB imaging, which shows beta-amyloid in living people, we have found that low HDL low HDL is associated with more amyloid in the PIB scan. A higher HDL is associated with lower PIB scan. Now, HDL, remember, as H for helper, and we want high H. And so the good news is that what we said was good for preventing stroke also seems to be good for lowering the beta-amyloid. Of course, this is not proof. This is just an association. And the same is true, there's an independent association between LDL cholesterol, I remember L as lousy. So when you have high LDL cholesterol, it's not good for atherosclerosis, and it's also not good for amyloid. So here's from our study. It's in press in the Journal of Neurology. This shows cortical thickness. Blue means there's atrophy. This shows the relationship between the amount of amyloid on a PET scan and atrophy. So the higher the amount of amyloid in a PET scan, more atrophy in the precuneus, here in the frontal lobe. But actually, a high HDL cholesterol, which is good for blood vessels, was associated with less atrophy in persons who already had some PIB positivity in their brain scan. So I think this is a very exciting finding, but it needs to be replicated. We're always looking for something that could be protective against Alzheimer's. So this says high HDL cholesterol may be protective. How do you raise HDL cholesterol? Well, we'll save that for the panel discussion. This is a slide from a transgenic mouse with the APP mutation, the presenilin 1 mutation, and a tau FTD mutation. Boy, poor mouse. I don't know any people that have 3 of these genes, but this mouse will develop rampant beta amyloid. And if you feed this mouse a high-fat diet, 60% of the calories coming from fat, well, the amyloid becomes even worse, like wildfire. So there is this interaction between the cholesterol and the diet and the amount of beta amyloid deposited in the transgenic mouse. Now this is another mouse. Can you see the tail and the head and the brain there? And this is an elegant study by Nedergaard, the senior author, last year. And this takes a long time to explain, but but tracers were put into the cerebrospinal fluid, and you could see that the beta-amyloid is cleared better during sleep. There's greater clearance. The interstitial fluid, so putting a tracer into the spinal fluid, it would get into the interstitial fluid of the brain. All the nerve cells and glia are bathed in CSF too. It's not just in the ventricles. All of our nerves and glia are bathed in CSF. And so that CSF, when we're sleeping, is able to clear beta-amyloid out around the venous spaces. So sleep is good. Now this is a cast from my colleague, made by my colleague of a human brain after death of all the capillaries and blood vessels in the brain. And if you lined our capillaries up end to end, they would stretch from Los Angeles to San Francisco. So we talk about neurons and neurodegeneration, but let's not forget how important the blood vessels are to this whole system. That's what we want to keep healthy and pulsing. So this is the vascular train that if you have vascular risk factors, you get cerebrovascular disease, which if there's occlusions or breakage of the blood vessel, you get a stroke, an ischemic stroke or a hemorrhagic stroke, and you get vascular cognitive impairment, right? You're damaging property. So this is called vascular cognitive impairment, vascular dementia, multi-infarct dementia, Binswanger syndrome. And so you can damage large arteries. This is something called atherosclerosis by high cholesterol and smoking. And in ultrasound, you can have narrowing of the artery. You can have narrowing of the small vessels inside the brain itself. This is called arteriolosclerosis, and this is accelerated by high blood pressure and diabetes. And diabetes also affects the little capillaries that are not even shown here, but we can see them in the eye. And in diabetes, you can put fluorescein dye in the vein, and you can see leakage of fluorescein into the eye. So we know diabetes affects the health of the capillaries. And in Alzheimer's disease, especially if there's an apolipoprotein E4, there will be deposition of amyloid in blood vessels. So this is amyloid angiopathy in Alzheimer's disease. Now the MRI scan is great for showing us strokes. The MRI scan is great for showing us volume and how much atrophy there is. Here there's a stroke in the distribution of the middle cerebral artery, and you see a huge stroke, and if this is in the left side of the brain, it's going to cause aphasia, loss of language, and a right-sided paralysis, and maybe loss of vision in the right visual field. We can see small strokes when a small blood vessel is occluded. These small little darts are called lacunar infarcts. And we can see lack of blood flow and injury to the deep white matter around the ventricle called white matter hyperintensities. And these are indicators of small vessel disease. Now there are certain location that will increase the risk of cognitive impairment versus blindness versus language loss. It's all dependent on location. And there are a few locations that will affect cognition more because they are locations that are important for cognitive networks. This includes the anterior limb of the internal capsule. Now, if you have a lacunar infarct in the posterior limb of the internal capsule, you get a pure motor stroke. So what happens if you get a lacunar infarct in the anterior limb of the internal capsule? It's cognitive impairment or some behavioral disturbance, more cognitive psychiatric. Okay? Maybe hold your question can you write it down and for the panel? There's a lot of longitudinal white matter tracks near those white matter hyperintensities, which are going to get slowed down by white matter hyperintensities. And then there are certain hubs in the thalamus that are connected with the frontal lobe. I'm going to show you those so you know where they are. Now, the memory network is, of course, the hippocampus. The hippocampus is fed by a branch of the posterior cerebral artery, the PCA. And so you can have an infarction in the hippocampus and then memory loss. And you can have a lacunar infarct in the genu, the knee of the internal capsule, which is between the anterior limb and the posterior limb, the genu. And that can cause a memory loss. Now, if you have infarction in the left middle cerebral artery, you're going to have aphasia, and that's going to affect cognition. And if you have it in the right hemisphere, the non-dominant hemisphere, you're going to have visual spatial problems. That's going to affect cognition. So that's basically how you get vascular cognitive impairment and vascular dementia. So just so you know, when you look at the MRI where some of these key hubs are, this would be the thalamus. This is the dorsal medial thalamus. It's very important in frontal subcortical loops. This is an infarct in the anterior thalamus. This is important in frontal subcortical loops. So these locations will cause a vascular cognitive impairment. So think of the thalamus as kind of an egg-shaped structure. They're kind of like mini brains. They're hubs for the whole cerebral hemispheres. And if you have an infarct in the front of this or in the medial part, these are strategic locations for vascular cognitive impairment. I like Dr. Brewer's talk emphasizing we have to quantify the degree of white matter hyperintensities. And this is the cardiovascular health study rating. Here's an 8. And this is a modified mental state exam. It really, white matter hyperintensities like these called RIMS, here's a 4, they don't really affect cognition that much. But when you're getting out to here, 6, 7, or 8, now you're going to see a drop in the modified mental state. But still, it's a relatively mild drop in the mini-mental state with these white matter hyperintensities. They look much worse than actually the patient, the cognition. Now here I'm a cartoon, I'm trying to convey that the impact of Alzheimer's, beta-amyloid plaques, and phospho-tau is very heavy on brain function. The impact of white matter hyperintensities on cognition is relatively mild, even though it looks pretty dramatic. The impact of a stroke on cognition is variable depending on location. Now, what are the risk factors for heart disease and stroke? Age, high LDL, low HDL cholesterol, high blood pressure, diabetes, current cigarette smoking. It's great to go on the internet and calculate our own scores and let our patients go onto the internet and calculate their scores. I think seeing your scores is very motivational. I went in an MRI scanner as one of those dummy brains for the harmonization, and I came out finding I had white matter hyperintensities. And that led me to double down on my blood pressure and my cholesterol. So when it becomes personal like this, we double down. And diabetes, I'm pointing to a website. There's probably many more, but these tools are neat when our patients and ourselves can access them. And I found this interesting. These are different kinds of strokes and different kinds of risk factors. This is cardioembolic stroke, say from atrial fibrillation. This is a large vessel stroke, say left middle cerebral artery. This is small strokes like lacunar infarcts, and these are other strokes. And these are the risk factors. So the greatest risk factor for all these kinds of strokes is high blood pressure, hypertension, across the board. And the second most common one is diabetes. The third one here is coronary artery disease. Then you have smoking. Then you have a previous TIA, and then you have atrial fibrillation. And that, of course, is high for cardioembolic stroke, but not so much for the others. So this is the risk of a stroke by severity of blood pressure. This would be stage 1 normal blood pressure. This would be stage 1 would be like 140/90, and stage 2 would be 160/100. And the risk of stroke is really increasing. So although high blood pressure is rarely cured, it can almost always be successfully treated. But only 70% of people are aware that they have high blood pressure. 60% are being treated, but only a third are being controlled. So there's this huge gap between what we could do and what we are doing in terms of lowering risk for stroke. There's lots of effective medications, and if the diastolic blood pressure is increased by 7.5 millimeters, the risk of stroke doubles. Diabetes in the epidemiologic studies is associated with a risk for vascular dementia. It increases the risk 2 to 3 times. It is also said to be a risk for Alzheimer's disease, increasing the risk by about 1.5 times. Well, we don't know exactly the mechanism for that. Diabetes is associated with slowing of speed. This is from the religious orders study, more so than memory or language or visual spatial. It's mostly speed, slowing. And diabetes is associated with more strokes at autopsy. But surprisingly, here's all the more strokes in people who have diabetes. But interestingly, with less Alzheimer pathology. And this is not just from the religious order study. We found it in our own data, and also the Vanta study and the Oxford study. So people say diabetes is a risk factor for Alzheimer's. It's doubling it, not doubling, for 1.5 times. But actually, it decreases the association at autopsy. Cholesterol. So this is an interesting story with pictures from the web here. There's hydrogenated fats and there's unsaturated fats where you don't have as many hydrogens, you have double bonds here. And in the early part of the 20th century, there came Crisco and other things to stabilize food products so they have a longer shelf life. And what was done was hydrogen was pumped in, and the fatty acids were partially hydrogenated. So you see that there's some hydrogens, extra hydrogens put in, but not completely hydrogenated. So these partially hydrogenated, sometimes when they're across from each other, they're called trans. If the hydrogens are on the same side, they're called cis. But these are called trans fats because the hydrogens are opposite to each other. So trans fats here are associated with more brain atrophy. Now, there's polyunsaturated fats, and that means that there's not all these hydrogens, there's double bonds here. And it depends on where the double bond is. If it's at the 3 position here from the end, it's called an omega-3 fatty acid, and those are good. But if the bond is at the 6th position here, see, 1, 3, 5, 6, it's called a omega-6 fatty acid, and those are inflammatory. So now you have to not only learn about HDL and LDL cholesterol, but omega-3 and omega-6 and trans fats. Okay, so omega-3 fatty acids are associated with less white matter hyperintensity. And trans fats are associated with more atrophy. So where what do we avoid? How do we avoid trans fats? Well, the simplest thing I heard someone say is avoid the middle of the grocery store. Because those are the things that have stable shelf lives. Okay, stick to the sides where it's refrigerated and fresh. Okay. So check here, cookies, crackers, pizza, hamburger buns, oh my gosh. Of course, French fries, chicken nuggets, hard taco shells, donuts, snack foods. And remember, if the label says 0 trans fats, it doesn't really mean 0, it means less than, I think, 0.5% or something like that. You know, when people say, well, what diet should I use? I mean, and I don't have time to talk about HDL cholesterol and omega-3s. I just say Mediterranean diet. And I'm Chinese, but American. But the Mediterranean diet has lots of fruits and vegetables and nuts and fish. It doesn't have as much red meat, and it's good not to have as much chicken even. And there are tables showing that if you have a Mediterranean-like diet, that you have a lower risk of heart disease. For physical activity, actually the studies say you don't have to be a marathon weekend warrior. You can just do something consistently, moderate, even walking. The importance is consistency. And it's kind of good to think about it like over a week. Get in 75 minutes over a week of getting your heart rate up to at least greater than 50% of your max, which is age-related. And here's the study showing whether high-level exercise or moderate level exercise are protective for cognitive impairment, and they both are. And so you really didn't need the high level, just the moderate level consistently. So here are like the 10 commandments for lifestyle modification, and if you can't remember those, then we'll go to the simple 7. But here, stop smoking if you're a smoker, lose weight if overweight, limit alcohol to less than 1 ounce of ethanol a day. If you're hypertensive, reduce sodium to less than 2.3 grams. Reduce dietary saturated fat and cholesterol intake. Avoid trans fats. Eat 1 to 2 grams of omega-3 fatty acids a day. Exercise aerobically regularly. Keep active mentally, socially, spiritually. I didn't show a data slide on that. And at least from the mouse studies, sleep well. And life's simple 7 here. Get active, eat better, lose weight, stop smoking, control cholesterol, manage blood pressure, reduce blood sugar. Thank you.